Med Surg department, and I thought maybe if we just go around and introduce ourselves, then we can kind of get to business.
Okay.
Hi, my name is Cynthia, and I'm the Quality Assurance Manager.
My name is Claire, and I am the Clinical Nursing Supervisor for the unit.
Hey, my name is Crystal, and I'm the Nurse Informatician for the unit. So, Matt?
Yeah, and my name is Matt, and I'm the staff nurse today.
Okay. Great. So, Emily, do you want to discuss the practices that are currently on the floor?
Of course. Okay. As charge nurse, I've kind of taken a look at some of the practices that are on the floor currently. The Med-Surg unit utilizes various evidence-based practices to minimize the disruption of patient turnover to nurses. The unit has specifically taken steps to ensure the staggering of new admissions and transfers among each nurse so that admissions, transfers, and discharges are not clustered all at once or for just one nurse. In an article published in the journal called Research in Nursing and Health in 2009, authors Jennings, Sandalowski, and Higgins reported that they reported a lack of predictability in new admissions and transfers from other units as being very unpredictable and having the ability to evoke anxiety in nurses. Accordingly, staggering new admits between different nurses and avoiding the clustering of admissions can help to reduce disruption to nurses while fulfilling patient care responsibilities. Also, in another study published in 2010 by the Journal of Nursing Administration, authors Cornell, Jordan, and Heron Griffith concluded that the use of electronic medical records and computerized provider order entry has also helped to streamline the workflow of nurses on the unit, along with the efficiency of admissions, discharges, and transfers. Utilizing forms such as these of health information technology over paper files can actually help the Med-Surg unit to be more effective and efficient in patient turnover. And that's all I have for current practices. If there's anyone else that has anything that they'd like to add about current practices with regard to patient turnover, feel free to chime in now.
So I want to say that I'm really happy we're all able to meet today to discuss the implementation of a turnover team. I think that Emily brought up a lot of really good points about current practices, and I think there are a lot of ways that we can do it better. In order to make our nurses feel like they're better supported and that they're able to spend more time with their patients. In a study by Jennings, Sandalowski, and Higgins in 2013 in the Journal of Research in Nursing Health, the authors were able to point out that nurses felt that turnovers, including admissions and discharges, really was a big stressor for them because some of the more complicated turnovers could take a lot of time from their other patients, especially during times like med pass. So we'll talk a lot about that today. I'm going to begin with an overview of our proposed intervention to implement this turnover team. It's been shown as a tool to provide high reliability health care. In a review published by Lin, Cheng, Shi, and Chu in 2012 in the International Journal of Gerontology, they were able to see that hospitals often discharge patients with insufficient planning, poor instruction, inadequate information, and an overall lack of coordination amongst members within the healthcare team, and that's something we want to improve in our facility. So again, in that published study by Jennings, they were able to see that most turnovers take place between 9 a.m. and 17:30 on Wednesdays, Thursdays, and Fridays. And so if we're able to get in a a discharge nurse, a nurse who is strictly working with our case manager to begin the turnover process. I think we can take a large burden off of the unit, especially if we start there. And there are a lot of, that means implementing new technology, and that means implementing, something new into our environment, which is going to affect the workflow. It's going to affect the other nurses on the team, and that's why we're here today to discuss the best way to get our whole unit on board. So.
All right, so kind of coming off of that, one of my duties as a nurse informatist, according to Alexander and Firth 2015 from our informatics book, is that I'm to analyze the workflow and process redesign for health IT implementation. So Jennings, Sandalewski, and Higgins, I believe those are the authors that Claire referenced, but it's from an article in 2013 from Research in Nursing Health. And they did find that nurses who experience turnovers during their shift do have a decline in communication and interpersonal relationships within the healthcare team. That includes with patients and with their families. This ultimately created a turbulent environment, and again, this brings on the stress, and of course, during the med pass, as Claire mentioned, turnover can be extremely stressful. So they identified two main sources for turbulence, and that was the time involved that they had to discharge a patient and the difficulty of the discharge, whether it's difficult or simple. So in order to simplify this process, we wanted to figure out an idea to simplify the EHR. And we thought, well, I thought, Claire, all of us discussed this on our discussion thread, that we could put a button on there for the discharge. So this button would be on the main screen of the EHR. You could click it, and it would be essentially a flag for discharge. This button would then have a list of priorities that nurses had to do in order to discharge the patient. And this was supported by an article by Prada Suarez in 2012. And yeah, so what do you guys think of this perceived implementation of this intervention?
I think that would be really helpful to have something like that, because in the past we've seen some workarounds with patient turnover. In the article by Jennings, Sandalewski, and Higgins, they pointed out concerns with the nurse staffing and timing associated with patient turnover. Particularly, we noticed that nurses were, let me grab it real quick. Sorry.
And Emily, while you're finding that, just to kind of go off of what I said before, an article by Hun, if I'm pronouncing that correctly, from 2007, he stated, and that's from the Journal of Biomedical Informatics, he stated that nurses, they really like order to their main homepage screen. So also if we could somehow find a way for nurses to organize their screen the way they think it should be. It'll have all the same features, but you'll be able to organize it in the level of prioritization. And again, that discharge button will allow you to organize your priorities based on that turnover.
Okay. That sounds good. The article that I was referencing was the Jennings article, and it was kind of going off of what Claire had mentioned previously about the transfers occurring during the day shift between 11 and 5. What they found was happening was nurses were prolonging the discharges in order to prevent the ability for new admissions. Because by having their beds full, basically according to census, it limited the ability for a new admit to be placed with that nurse. So I like what you're saying about having the nurse being able to have kind of a hand in things and being able to prioritize different things.
Yeah, and from personal experience, I have witnessed where nurses would like to keep people in their beds because admissions take so much time and effort, whereas discharges you can kind of, know when it's going to occur for the most part.
Mm-hmm.
That's true, and I think that's also supported by evidence in that article by Jennings. Again, to reference that piece, they did state that overwhelmingly nurses said that yes, they felt like they had more control over discharges and that they knew when they were going to happen. And I think that the discharge button that Emily is talking about would help expedite that process, especially if somebody else is working with them. And that so does anybody else have anything to add about that discharge button? Any possible pros or cons to that process from the staff nurse perspective?
In particular, I think it's a wonderful idea, obviously, because everybody's on the same page in terms of timing at that point. Once that button has been pressed, you know what the next steps are going to be, you know what the next expectation should be, and then you can get ready for the next patient after that. And it just also decreases the amount of face-to-face time or interruptions between the discharge nurse and the staff nurse as well. If they can see it electronically and communicate back and forth that way, I think all can benefit from that.
But to kind of come off of that point, an article done by Edwards in 2009 from the International Journal of Medical Informatics found that multitasking can kind of create a highly interrupted workflow. So just to add on, I think it's really important for nurses to focus on one thing at a time. If you're discharging a patient, don't be looking at the computer, kind of get in those habits so that you don't have that interrupted workflow and don't lose your train of thought and don't forget about meds for other patients and things like that.
Exactly.
Yeah, absolutely. In that article that we were
Oh, I think we lost Claire.
Yeah, I think so too.
Yeah.
I think we need a lot of input from our staff nurses. They said that things like having the availability of the computers.
Hey, Claire.
Yeah.
You kind of tuned out. I don't know if your signal was lost. Could you repeat what you were saying? Oh, I think your signal's lost again.
Shoot.
Well, maybe while we're waiting on Claire, I can bring up one more article that would kind of be a pro to the button that you were talking about.
Okay.
There was an article published in 2006 in Health Research and Educational Trust by authors Unruh and Kotler, and it emphasized the concept that current nurse staffing policies don't take into consideration the immense workload created by patient turnover, and therefore it leads to insufficient staff levels when nurses are needed most, which is at the time of patient turnover. So having something like that to help the nurses prioritize their time and help make their time more effective and more efficient would really help with nurse staffing, I believe.
Great. Yeah, I think one of the most efficient ways to integrate our evidence-based practice that we've all referenced is to embed these ideas into the clinical decision support system, which is what our authors, Alexander, Firth, and Hoy, in our text, our informatics text, talk about. And I think this will definitely impact clinical decision making about individual patients at the moments that those decisions need to be made. So I think it'll be a good way. Cynthia, hopefully Claire will come back soon, but if you would like to maybe talk about how we would possibly evaluate this EHR button method.
Okay, so as far as just giving some background again, an organization's workflow is made up of a set of processes that need to be accomplished, people or resources to perform these processes, and interactions among them. So that came from Kane and Haig from 2008 in Patient Safety and Quality, an evidence-based handbook for nurses. So, and I know as previously mentioned, the problem is disruptive turnovers, specifically like the discharges. So being the quality assurance manager, a quantitative approach would be utilized to determine the efficacy of this new discharge button. So according to Firth in our Applied Clinical Informatics book, 2015, if health IT is designed properly, the amount of time for delivery of medications, supplies, and equipment can be shortened. Thus, discharges would be completed with more ease, and two major factors that influence the outcome of these discharge rates include the usability of the health IT, in this case, that discharge button, and the plan for its implementation. So the discharge button's interface should be designed with a simple and consistent appearance so that the user doesn't have to remember a series of steps to complete tasks or have to do extensive digging to find the necessary information. And then the system should also allow for corrections, efficient interactions, provide cues if information doesn't correlate, and use a universal language. So as far as studies, a study by Garg, Lee, Evans, Chen, and Xie in 2015 in the, let me pull that up, the Joint Commission Journal on Quality and Patient Safety. They did discuss that use of the EHR discharge checklist. So they found that that checklist helped physicians to complete the discharge tasks. It improved their confidence and increased their efficiency of the process. And then also an article by Apker, Breach, Lang, Cheng, and Wares in the journal Proceeding of the International Symposium of Human Factors and Ergonomics in Healthcare also found that these tools enhance transfers and patient continuity. So the implementation of this discharge button should decrease discharge time and increase ease for the discharging nurse. So as far as a quantitative approach, I was thinking the discharge process should be timed. So we would do timing of the discharge prior to the implementation of this new discharge button, and we can do that over, so we're thinking since we're doing like a 3-month trial is being discussed, so we would take all the times prior to that 3-month trial and then time the discharge process after that 3-month trial and have an evaluation of if there actually was a decrease in that time. Also, the discharge nurse would be given a survey. And so I have a couple questions that we would ask them, and it would be like a pre-test and a post-test. So one would be, I am knowledgeable about health information technology and how it relates to patient turnover. 2, having a turnover team interrupts my workflow. 3, the discharge protocols allow me to complete discharges in an efficient and timely manner. 4, the discharge protocol is frustrating and interrupts my workflow. And 5, maneuvering through the discharge documentation technology is difficult. So each of these questions would be, so most of these would be answered using that Likert scale with strongly agree, agree, neutral, disagree, strongly disagree. And basically we just compare after the implementation to answers prior to also evaluate the efficacy of this new button.
Yeah, that sounds great. Hi, Claire. We saw that you had some technical difficulties, and we kind of just forged ahead.
Yeah, I was able to hear everything that was going on in the meeting. Google just had a small issue, so you could say that I had to step out of the room for a second, but I was able to hear. I think that Cynthia came up with a great survey, and I think our nurses will also be very happy to know that they have an involvement in this step, and I think that they're also going to be grateful to be sort of educated on this discharge button, and to know that it's not just going to be something that our turnover team will utilize, but something that they'll be able to utilize themselves when they're implementing a discharge on their own time when the turnover nurse is not there. So did we talk about, and so we are going to educate. Emily, do you think that that's something that you'll be able to get the nurses on board, or that you will be able to get our nurses on board on the unit with that?
Definitely. I was thinking that as charge nurse, my time with the nurses during morning huddle would be an ideal time to talk about the new discharge button, maybe demonstrate how it works, and talk about how the turnover team will come in to assist them in this process. And that way, if they have any questions or would like to see a demonstration, at that point we could take care of that.
Great. And Matt, what do you think about that as a staff nurse? Do you think this EHR button is a possibility and that it'll be efficient and easy tool to use, or?
Yeah, I absolutely do. And I was also going to just try to transition to, one of the roles or one of the expectations of me was also to come up and to discuss like the optimal location of where the discharge team should be physically located.
Great.
Do all believe that this is a good time that we can transition into that as well?
Yes. Yeah.
Okay, perfect. Well, first of all, as a staff nurse, one of the things that we need to do is find out where this team should be located, and also the reasons why that this location is important. And number one, I'm proposing that first that the discharge team needs to be located away from the medication room. I feel like it's very important that the discharge team needs to be located where minimal distractions and disruptions are likely to occur. And the reason for this is to decrease any distractions from the discharge team that could lead to medication error or distractions of those administering medications. Obviously, being nurses, our top priority is to help individuals and try to create as less or as few errors as possible. And second, I would propose that the discharge teams need to be located away from the nurses' station. And the reason behind this is to avoid disruptions during patient handoffs or shift changes or charting. And according to the recommended readings and the Jennings article that we've previously mentioned, interruptions actually rank first among factors that lead to increased nurse workload as well. And I think that one of the goals of a discharge team is actually obviously to decrease the primary nurse's workload and not increase it by increasing the amount of interruptions. And also discharge teams should free up some of the primary nurses' workloads, allowing primary nurses to perfect some of their nursing skills on patients and not be boggled down by the time it takes for discharge as well. According to an article titled Comparison of Nurse Workload Approaches published in the Journal of Nursing Management, Beswick and others concluded that a discharge team allows the nursing staff to perform their duties while allowing some of the workload burden to be directly shifted to the discharge team. Therefore, a second reason why discharge teams should not be located close to the nurse's station is because it will allow them to have fewer distractions as well, and this allows the discharge team to formulate a strong and effective discharge plan for each individual patient. Each patient will then have a clear understanding of their plan upon discharge, and hopefully this may decrease readmission rates in the future for the hospital as well. According to Phillips and others who published an article titled Comprehensive Discharge Planning with Post-Discharge Support for Older Patients with CHF in the Journal of American Medical Association, found that readmission rates actually decreased, improvement of outcomes along with the quality of life increased when patients had a strong discharge plan set in place. And finally, I would propose that discharge teams should be located probably near the charge nurse or the unit supervisor. And the reason for this, because I believe it will lead to better communication regarding staffing needs, along with keeping a close eye on room occupancy and any issues regarding communication between staff and the discharge team. So in terms of, obviously the electronic side to this intervention, but there's also the physical location of where the team should be. And I just think that the team should be probably located closer to the charge nurses or the unit supervisor versus the actual nursing desk or station as well. Just trying to think, those are my reasons for what I propose, and wanted to get any feedback, or at this point we can turn it over to Claire for the recap of our group's intervention as well.
Well, I certainly agree. I think that the turnover team should have a distinct location, and I think that being in that area would definitely improve communication. In that article by Jung and Lipinski that we had referenced earlier, they said that a lot of the staff nurses often felt that they weren't able to access their computers because they were being taken up by other clinical staff, whether they be physicians or maybe the turnover team. That could have been part of our problem with the staff nurses previously feeling like their workflow was being interrupted. Does anybody have anything else to add about the location of the turnover team?
I did have a question about the time when the discharge team would actually be on site. In the which article was it? There was an article that talked about when the discharge team was on site during specific times, there was a higher interruption in. Sorry, guys, bear with me. Here we go. Okay. In a 2005 article published in Nursing Management, Joyce et al. Acknowledged that historically patient turnover teams work during the day shift. And in the Jennings and Sandalowski and Higgins article that we've already mentioned, they pointed out that over 30% of admissions, discharges, and transfers occurred during the day to night shift transition, representing a gap in the services provided by a discharge team. If the turnover team was available during both day and night shift or during the transition between day to night shift, I recognize that that might help out with the busy time for nurses and the disruption caused by patient turnover. I was curious as to when the discharge team might be actually on site.
Hopefully it's something that we're going to be able to transition to having a turnover team there, almost all of the time. Okay. I know that the literature published in Jennings supported that the majority of turnovers took place between 0900 and 1730. So we were looking at having them available during the day shift. But I think that Emily brings up a really important point in that we probably should try, at least at some point, to have that turnover team available during change of shift, because that's also a stressful time when you're trying to turn over all of your other patients and having to worry about discharges at the same time. So again, hopefully we'll be able to transition the team there, 24/7. And I think that the surveys that Cynthia came up with were excellent. And if we're able to find that the staff nurses find this helpful, we'll be able to transition to having more coverage over with our unit.
Sorry.
Any other thoughts?
Yeah, plus I was going to say that with the survey, we would be able to make adjustments as needed. So I know that one of the questions was having a turnover team interrupts my workflow. So I think if that happens to be the case, we could have some follow-up questions and ask them what about it interrupts the workflow, and have like more of a qualitative approach to evaluate the situation as well. Same thing with just having the discharge button in general. Once we evaluate it, we can always make adjustments to make it better, and just keep, just always having new suggestions with the evaluation, and then having follow-up questions to just improve the system in general.
Wonderful.
As far as the EHR button is concerned, the discharge button that we've talked about as our intervention, how long do you think it would be a good time to have these nurses kind of habituate to the button and to do that post-survey? Like, what's the time period that we're thinking of that?
Right now, I have it at 3 months. So we'll have like, we can time discharges prior to those 3 months, then time them again at 3 months. That way the nurses kind of get used to it for a couple months, and then make adjustments from there on, and then probably have like another 3-month course to have them take the same survey.
Great. I think that's a good way to measure our outcome for this intervention. So, is there anything else anybody would like to add? Okay.
Yeah, I guess I can wrap it up here. And you know, there was an article again by Lin Chang Shi in 2012 in the different Lin in the Journal of International Journal of Gerontology, that said that there was an improvement in patient satisfaction coupled with a decreased length of stay and a decreased hospital readmission rate when discharge planning and execution is relegated to a specific nurse or interdisciplinary team, which would be our turnover team that we were looking at, having this turnover nurse, you know, working in conjunction with our nursing case manager. Those authors went on to discuss that discharge planning and execution, again, it improves all of these things. So decreasing readmission rates is something this hospital really wants to improve upon because it affects the way that we're compensated by Medicare. So, you know, this having this individual who's really able to put a lot of their time into evaluating the patient's needs and coordinate with the nurses, I think will ideally be better for the patient, and hopefully the staff nurses will feel like their workflow is not being interrupted because we've been able to pull this interdisciplinary team together, especially having Matt from, you know, as a staff nurse chime in and come up with some solutions to improve the ergonomics, so to speak, of the workflow. And, you know, Cynthia's survey technique will certainly, you know, hopefully get, you know, clue us in on any areas where we can continue to improve. Does anybody else have any final thoughts?
Nope, none here.
Good.
Okay, great. So I'm looking forward to getting this this intervention put in. We definitely have a way to evaluate that outcome in another 3 months. So it was a good meeting, and I think we'll really be able to improve our healthcare team, and we'll see you guys in 3 months when we re-evaluate our turnover team intervention.
Yep, sounds great. Thank you, guys.
Thank you, guys.
Thank you.
Thank you.